Hello.
Hello, Doctor.
Okay, let us start, please.
All right. So, Assalamualaikum warahmatullahi wabarakatuh. Good evening to Dr. Mossad and fellow friends. Okay, we start our discussion, our sharing with Umul Kita Al-Fatihah. Okay, Alhamdulillah. Thank you for joining the presentation, Doctor, and fellow friends. So today we will be sharing about some of my friends. We're sharing about their assigned procedure presentation. So my name is Muhammad Azlan. I will first to be the presenter. So first topic will be hand wash, PPE, and blood culture and sensitivity. Next slide. Inshallah, it will be quick as you propose to focus on the practical points. Okay. Next, Iza. Iza, next.
Can you make it full screen?
Oh.
Sekarang nampak apa?
Nampak tak full screen, tak full. Cuba slide share.
Oh. Dah tekan full screen.
Oh. Lepas tu, oh ya ke?
Sekarang nampak slide mana?
Nampak slide first.
Oh ya ke? Macam mana?
Tadi tekan ni. Full apa? Over apa? Macam mana? Okey tak? Ke
Sekarang nampak apa?
nampak slide? Full screen?
Tak bergerak
Cuba second slide. Tak gerak juga.
Oh dah gerak dah sebenarnya. Macam mana tak tahu.
You can press F5.
How?
F5.
What's that?
The bottom of F5 in the upper, the keyboard.
F.
You have F1, 2, 3, 4. Go for 5. Just press function and then press F5. It will be full screen.
Actually, this is my first time sharing at Zoom, so I'm not sure how it works.
Iza, maybe you can share the slide to the group so that someone else can share the slide.
I'll try to share because I have the PowerPoint also. So I will try to share. Can anyone see?
Yes.
Yeah, okay. So full screen?
Yes.
All right.
Yeah.
Okay. So we'll proceed for the first topic, hand wash. So, okay. So hand wash is a critical component. You must remember and always practice about the infection. Hand wash is to prevent the infection and to control. It's important because it can yeah, it's safe for us and also for the patient in terms of organism transmission, isn't it? And then you need to remember about 5 moments of hand hygiene before you touch the patient, before proceed with the procedure, or after exposure of the procedure, and then after touching the patient or touch the surroundings. So you need to practice, okay? And then remember when to perform the hand hygiene. There are 2 types of hand hygiene: hand wash and hand rub. Okay, and then just move on to the step of hand wash and hand rub, because it's the most important you need to know. Okay, this is the picture. All right, so I believe everyone knows about the step. So just I recap back. So first, you need to remove all the accessories in the over your hand and over the arm. Okay, and then wet the hands with water and add some soap. Okay, first you will rub the hands palm to palm, and then next to the dorsum part with interlaced finger and vice versa, and then proceed with palm to palm again with fingers interlaced. Then you proceed to clean the you know, the dorsum of the fingers if the fingers interlock, and then proceed to the clean the thumb, rotational rubbing, yes, rotational rubbing, and then to the fingertips, clean the fingertips by dipping all the fingertips onto the palm and vice versa. Lastly, rotational rubbing of the wrist, okay, and vice versa. For the surgical purpose, you need to rub until the elbow. So yeah, and then rinse and wipe dry. Okay, so next is hand rub. Okay, the difference is in hand rub and hands wash is hand wash by definition by WHO using water and also soap. That's the definition of hand wash. For hand rub, using the alcohol-based hand rub. Okay, so there's similarities and differences only at the initial step. So by dipping all the fingertip and then followed by rubbing palm to palm, and then proceed to until as you can you need to practice until you can get used to it. Okay, so it's the step is somehow similar.
Aslan,
Yeah.
just for the one to the right, upper one to the right, you are cleaning like that. Okay, there is no school for that. Either doing like that, but if some person cannot come just to cover, we can do it from front like this.
Yeah.
Okay.
Yes.
You see my hand?
Yes.
Either put it like that. Okay. So, or if you are able just to go above it, it is recommended by some schools. But we have, but the most important is the timing between hand washing and hand rub.
Yeah, yeah. Actually, there are another difference. Like you mentioned, how to clean, how to rub the back dorsum of the finger. But this one I took it because I usually use this step. But yes, by what you said, it is also acceptable. Okay, so everyone need to really know about this step. So similar in surgical posting, we do these things during in OT. So it's similar. Okay. All right. And then PPE. Okay. So how to don and to doff PPE. Okay. Before talking how to don and doffing the PPE, let's just recap. We have learned this during re-education program, and then we had the exam, right? So there are 2 levels in PPE, level 1 and level 2. So in level 1 is a basic one where that we use when there is no suspect or known infectious agent exposed. Okay, so what to wear is just a simple thing. We do the plastic gown, okay, plastic apron, sorry, and then surgical glove, and then surgical mask. All right. So and then level 2, there are 3 categories: contact and droplet. Lastly is airborne. So contact and droplet is similar. Their wear, okay, similar. So when to use is when there is suspected or confirmed infectious agent spread by direct or indirect contact. So such as ESBL, MDRO, MRSA, okay, and just add to the isolation gown. The rest is similar, okay. And airborne, like current pandemic COVID-19. So we use this kind of PPE level 2. So yeah, there is suspected or confirmed infectious disease of high consequence, where it can be spread by direct and indirect contact, especially COVID-19, Ebola virus, Lassa virus spread by airborne route. Okay, so what to wear is there is additional where we need to use N95, head cover, and boot shoes cover. The rest is similar. So I get a video, right? I get a video from USM. So this is the local procedure. Okay, sorry. Okay, here. Can you see this? So 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 just look at the step. I think it is important because maybe in our to future, in future, maybe we really need to know this step. Okay. Oh, sorry. I'll try to make it quick. Okay.
Sorry, Azlan, I don't think there is any video showing.
Oh, yeah.
Yeah.
Sorry.
All right. Yes, now yes.
Oh, okay.
Okay.
Sorry. Okay. This is a quick step. Okay, this is from USM in our local other local university. Or I think yeah. Okay, so this is PPE level 3. So as you can see, every step they need to do hand hygiene. So it's important step. Need to know that.
Donning and doffing. During both donning and doffing.
Yeah. Oh. So from the videos, okay, so you see all their exposed part of the bodies are very closely covered because they don't want to be exposed to any infections, okay, inhalation or injection, okay, or skin contact. So it's very important usually in this pandemic. So okay, so this donning, so we look at how to doffing, how to put off. So I think that's all for donning and doffing for PPE level 2. All right. So from the videos, we can say that every time hand hygiene is very important, and then to fully cover is we need to master the step. Okay, how we want to master it by experiencing. Okay, experience it during our inshallah future. Okay, so next move to the blood culture and sensitivity. All right, so blood culture and sensitivity. So proceed to the practical parts. Okay, as usual, I bet everyone may have experienced how observe, at least observe the blood CNS. Okay, they need syringe, needles, aerobic and anaerobic set bottles. Okay, and then pediatric bottles, you can see the volumes, the difference between adult and pediatric bottles is the volume needed. So in pediatric, we only need 3 milliliter blood volume. Okay, And then of course we need chlorhexidine wipe, cotton ball with tape, sharp bin, and etc. Sterile dressing set is part of important things to have. Okay, so how we want to take the blood? Okay, first of course we need to do this introductory things first. For example, you need to introduce yourself to the patient, confirm the patient identification, explain the procedure. Okay, about it's a simple step, but it's quite complicated. You need to remember the step. So you need to inform the patient regarding blood taking. Okay, gain their consent, and then position. Okay, as usual, you need to really make the patient comfortable, and then ask for their preferred location. You need to look for it. Okay, and then the procedure. Okay, so I think I have a video. Okay, you want to watch video, or I want to to talk? You want to watch the video or
Watch video.
watch video? Okay, okay. So I took from or other local, other local videos from University Malaya. So the step is quite simple. All right. So okay, here. All right. Can you see? Can you see?
Yes.
All right. Okay. So I'll try to make it fast. So this introductory speech between patient and physician. The step before that is to confirm the identification. Okay, so yeah, I think for you to be I think you need yeah, to rewatch, or yeah, maybe if you want to master it by experience it lah. I have experienced it during internal medicine year 3 in year 3. So it's quite difficult for the first timer, but I think it will be better time to time when we experience it, do it. Okay, so yeah, all right. So okay, I think that's all from my part for the practical point. So the difference in adult and pediatrics black culture, is it the indication? Okay, the indication why we do black culture and sensitivity, because one of the indicated, I think we'll share it through the in the quiz later on. About the quiz, I have mentioned about indication, but here I just like to highlight that we want to confirm the diagnosis, and then we want to know the etiology. And then for the it's the same, but the difference is a 10 milliliter for the each bottle, and then for pediatrics it's only 1 to 3 milliliter for pediatric bottle. And then you must make sure that the first to fill up the bottles is the aerobic first, okay, the aerobic bottles, and then second followed by the anaerobic. All right, so I think that's all. So we proceed to Muhammad Fatul.
Before you go to the other, you didn't answer my question. So what is the difference between hand rub and hand wash?
Okay, so hand rub and hand wash. Okay, the difference is first is the timing. Usually we, of course, hand wash will be 40 to 60 seconds. I mean, okay, and then the difference is yeah.
Can I try?
Yeah, sure.
Basically, hand wash, it covers most of the microorganism, while the hand rub covers partial, I can't remember what organism it is. And then the durations of doing the procedure, hand wash is basically longer, taking more stepwise compared to hand rub. And then hand rub, it can open anywhere, and it doesn't what we call that disturb it doesn't bring any harm to the skin because it contains the moisturizer, and basically it is fast. But using a hand wash is there's a certain condition of using hand wash, for example, after eating or after toileting or during antiseptic procedure that require high aseptic procedure.
Okay, so you need to revise that slide, Aslan.
Yeah, Doctor.
You need to revise and correct this and add this important point to know that the hand washing is 40 to 60 seconds, but the hand rub is 50%. It means from 20 to 30, but you must do all the steps.
Yeah.
And the hand washing indicated, of course, after eating. If this is the first time to come to the world, it's better to do hand washing with many other differences. I think for the microbes coverage, it is good. It is both are okay. The only thing you must do the all steps. Okay, otherwise it will not be effective. And the one which combine both, that both of them are the benefit of the patients, and both of them consider ibadah. Ibadah, like washing a hand for wudu.
Yeah.
It is the same. You must wash your hand to prevent harm to the other, because Allah prevent a Muslim to do harm. Okay, for anyone. The other thing I send it to you, Aslan, because our hospital really did a very, very, very nice program about infection control at the start of the COVID problem. And really, it looks at the start that it is a bit difficult because all the staff will not start unless they pass the infection control program. Whatever you are, MO, house officer, consultant, specialist, all must pass the test. Otherwise, they will not allow to practice. It was very, very good. I send for you some of its parts, and they make it. You can ask someone in the administration if it is recorded there. They make 10 stations to be examined for everyone, one only for hand rubbing, and you must pass. If you didn't do it correctly, you may fail. One for personal protective equipment, either 1 or 2 or 3, and the other like chemicals, how to prepare for blood culture. It is very, very nice. I hope if I pick it, I will drop it to you. It is very important. But I send you Aslan some. You can give it to all year 5 even.
Yeah.
Okay.
Sure, Doctor.
Ask the one, because it will help you during the preparation of that issue. The other thing, you must be ready by theoretical part, but you must, they teach us before, try to see once, do one, teach one. This is the life. Maybe this one need to be repeated, no issue, but you must observe 1 and 2 and 3 times. And if you have a chance to do it, do it, okay? And after that, don't say, oh, I will keep this skill for myself. I will not teach anyone so they will be better than me. This is, I think this is a very, very, very bad behavior for any one of us. Even the Prophet ﷺ said, Man katama ilman, the one who knows some beneficial ilm or knowledge, aljamahu Allahu bilijamin min nar. He will punish him very bad punishment. So don't keep the knowledge on your side, and be happy if you give it to everyone, okay? Because
Okay.
it is sadaqah in Islam also to teach the knowledge to one who doesn't know or know it partially. Good. The last point for me is the doping, because there's many studies why some medical practitioners got COVID. They found it because of the incorrect sequence of doping, not doing. They make doing completely okay, and during the doffing, they forgot and touch the mask wrongly, like that. So it is very important to know the sequence, and for every step, you must clean your hand completely. Okay. I hope it is clear for you, because sometimes you will make a very good job, but the same as the one bring some food and put something bad over it. Okay. So take
Okay,
care
Doctor.
about that, please. Okay. Thank you.
Thank you, Doctor. Thank you for the points which may miss about the dosing, the importance of dosing.
Yes.
Okay, thank you, Doctor.
Welcome. Now ECG.
Okay, so we proceed to ECG, Fatul.
Okay, Assalamualaikum. So I am Fatul Hakim. We present about the ECG. This is my table of content. First, I will present about indication and risk. Second, about lead placement, and the third is the interpretation of.
Can you increase the volume? The voice is not so clear.
Hello. Okay. You can hear now.
Can you increase it more?
Or you can
hello?
make
Hello?
your voice more loud. Forget the volume. Make your own volume.
Okay, I will try. Hello. Can you hear now? Hello.
Yes, we can hear you. Just
Okay.
the volume is macam slow sikit lah. Boleh dekatkan mic tu kot.
Okay.
I think it's better.
Okay je.
Okay je.
Cuma kuat sikit.
Sorry. Okay. Saya cuba kuatkan. Okay. So kita proceed. Next. The next slide ke? Indication. Okay, so this is the indication to do ECG in pediatry. Basically, it's the same with the adult. So if it's copy, tachyarrhythmia, bradyarrhythmia, I think you know of this. And that is for the complication, there is no complication related to ECG. All right. And some children may have reaction to the adhesive used to attach to the ECG, but generally there is no serious complication related to ECG. Okay, next. So we are going to place the ECG. We have two types of lead. So first is limb lead. So basically limb lead should be placed on the limb, not on the torso. So it's similar to adults. We put it on the arm and leg. So arm lead should be placed just above the elbow. Leg lead should be placed between the knee and ankle. It's just the same in adults. Okay, next. For the precordial lead, so it's also the same as adult. V1, V2, V3, V4, V5, and V6. First, we locate the intercostal space and we search for fourth intercostal space and put it V1 and V2, right and left, half inch, okay, from the midline. And then we put the V4 first. V4 first at the fifth intercostal space at the mid-clavicular line, and then you put the V3, and then V6 and V5. And then, but how about in ECG placement in infant or toddler that you cannot locate the rib space or you cannot feel the rib space? So basically your point is, your reference point is at the nipple line. So V1 and V2 nipple line at the nipple line, V1 at the right and V2 at the left. And then V4 is below the nipple at the nipple line, and V5 and V6 V6 is almost the same, and V3 is between the V2 and V4. Okay. So this is the so we're going to do the easy interpretation. So heart rate and rhythm. So you must know if the patient rhythm is regular or irregular in order to calculate the heart rate. For the regular, we use count off or RR distance method, or irregular, or for irregular rhythm we use NAN over 10-second method. Okay, next. So this is for regular rhythm. Okay. For the count of method, I think you all know about this. We calculate uh, how many large square present within one RR interval, and divide 300 by this number to calculate the heart rate. And then we have RR interval method. It is more accurate compared to count of method. Basically, we count the number of small boxes multiply with 0.04 seconds, because one small boxes is 0.04 seconds. And then divide 60 with the number, and then you will get the heart rate. As you can see in the picture below, there is 167 minutes. Use this method. It is more accurate. Okay, next. For the irregular method, we use 6 over 10-second method. Basically, you count QRS complex. If you count the QRS complex in 50 big boxes and you multiply with 6, but if you count the QRS complex in 30 big boxes, it times 10. Okay, so this method is used in the irregular. Okay, next. Okay, so the P wave has amplitude and duration. So for the sinus region, it is defined. The criteria is every P wave followed by QRS complex, and every QRS preceded by only one P wave, and the P exists between the 0 and plus 90 degree at all age. This is the normal. So basically, if you can see in the voltage picture, it is 0 to positive 90 is between 1, the blue line, to the ABF. So the upright P wave in lead 1, 2, and ABF, it should be upright P wave. But in lead ABR, it should be negative P wave. And then moving on to the amplitude, the P wave amplitude is less than 3 millimeter. 3 millimeter. So basically, less than 3 small boxes. Okay. So if it is tall P wave, it indicates that the right arterial enlargement. Okay. For the normal P wave duration is less than 0.0 in children and more than 0. Less than 0.07 second in infants. So if P wave duration is longer, it signifies the left atrial enlargement. And if there is P wave amplitude, the P wave amplitude is high and the P wave duration is longer, we can consider it as combined atrial enlargement. Next. Okay, so this is the PR interval. Basically, PR interval, we want to look for any heart block in it. So in adult, PR interval is between 120 to 200 milliseconds, or 0.12 to 0.2, which is mean 3 to 5 small boxes. But in pediatric, the PR interval is shorter. However, as you can see in the boxes, the right box, it will slowly increase as the child become older. Okay, next. So for the QRS axis, amplitude and duration. So you have to know that at birth, right ventricle is thicker because the right ventricle needs to pump blood from the mother in the fetal life to supply to the systemic circulation, and increasing in age after birth, there is increasing muscle mass of the left ventricle because the left ventricle need to do the job to replace the right ventricle. Okay, so basically, as you can see, QRS axis of the heart. So you took lead one and lead AVF. Why? Because lead one represent the left side of the heart. As you can see in the voltage picture, lead one represent left side of the heart, but AVF, the downside, represent the downwards and upward. So if you can see that if lead one is positive and lead AVF is negative, so basically it is possible left axis deviation. If we let point negative and AVF is positive, it represents right axis deviation. And it is negative, it may be extreme axis. Okay, next. For the amplitude, we look at the lead V1 and VC, which is the precordial limb. So you know V1 at the right side of the sternum at the fourth intercostal space, and VC is at the mid-axillary line. So lead 1 represents the right side of the heart, and the lead V6 represents the left side of the heart. So right side is larger than the left. So the R is longer than the S wave. However, as the child becomes older, the S wave is going to be longer than the R wave. So this is vice versa to the V6. Okay, next. Okay. So QRS duration is shorter in the pediatric because less muscle mass compared to adults. So in adult, the normal QRS duration is 3 small boxes. And if you can see that I put that age and QRS duration at birth, yeah, it is less 0.075 seconds or 75 milliseconds. Okay, next. For ST segment and T wave, there is some physiological in the pediatric. As you can see here, first segment, there is T wave inversion of the right precordial lead in the pediatric. It persists until before 8 years old. So an upright T wave before 8 years old is indicative of right ventricular hypertrophy. And if you see any Q wave in lead 1, AVL, V5, and V6, it is normal actually in a pediatric, provided the amplitude is less than 5 millimeters, so less than 5 small boxes. So you can see also the RSR pattern, or we say rabbit ear of the right precordial limb, that provided that QRS duration is less than 10 milliseconds and the R amplitude less than 15 millimeters or 10 millimeters children. And there is also elevated J point. However, I don't know why this normal physiological happen in the pediatric. Okay, last but not least is I think it's the QT interval and QTC. So basically, QT interval is the time from the QRS to the end of T wave, and then QT interval is actually important in the identification of individual at risk of life-threatening asthma. However, it is not accurate because the relation between the QT interval and the heart rate and the children itself have variability of the heart rate. Okay, so they use the corrected EC. So upper limit of normal duration for infant less than 6 months is less than 0.49 seconds. However, in older than 6 months, it's less than 0.44 seconds. Next. Okay. This is how you calculate QT T. So QT in seconds divided by a square root of RR interval. So as you can see, it's QT interval there, 6 small boxes, and then the RR interval is 9 small boxes. So you divide 0.25 square root of 0.36 seconds, so you get 0.4 seconds. The QTC in this in the pediatric is normal. Next. This is the additional information about the hypertrophy. Is the left hypertrophy. You guys can read it. And next is the about the this is ventricular hypertrophy, but we use next slide. Next slide. Hello. Okay. So basically, this is what I mentioned, the ventricular hypertrophy. So we look at the V1 and V6, but in adult, we look at 1, 2, 3 for our discussion. So we focus on V1 and V6 for pediatric. And for the next slide, the next slide is the criteria in diagnosing right or left ventricular hypertrophy in the children. Okay, okay. Next, that is easy. Okay, then we proceed to electroencephalogram. So this is the outline. So one, introduction to mechanism, 3 components. So for the introduction, so we use EEG to analyze the electrical activity of the brain. Is it any abnormal activity of the brain? So next slide. So the abnormality of the brain can be due to many causes, such as seizure, head injury, encephalitis, brain tumor, memory problems, sleep disorder. So also you have to know that EEG can be performed to determine the level of brain activity during anesthesia. Okay. Next. Okay. So here is the risk of EEG. So it is a safe procedure actually. It causes no comfort at all. But in rare instance, EEG can cause seizure because they might involve flashing of light or the deep breathing to stimulate the brain activity. Okay, for the factor or condition that interfere with EEG reading is like low blood sugar, body or eye movement, light, or drink that contain caffeine and oily hair, because the presence of hair spray, because there is disturbance in electrical transmission. Okay.
Also, if the patient in high dose of like loading a dose of anti-epileptics sometimes can cause some changes if it is high dose like that. So we are considering the balance.
Okay, thank you for adding the point. Okay, so how we do how the EEG works. So basically, the billion of nerve cells in the brain produce a very small electrical signal that can call brainwave. And this brainwave is first detected by the electrode. So it will record the EEG changes in the brain. And then it will transmit to the amplifier. Sorry, the two is the amplifier. It will receive and amplify the brain signal to electrode, because the brain power is so small. So we need to amplify it. And the third, it will direct to the filter. So we can produce a clean and readable result. And last but not least, it will go to the writing unit and it records the EEG on the paper, just like ECG, it record the EEG on the paper or in the electronic, and it's going to be interpreted by the physician. Next. So component, like I said, is first is electrode. Okay, so you know the function already is to detect the brainwave, but how to position this electrode? We use the 10/20 system. So basically, each electrode labeled with a letter and number. So even number, the 10, 8, 7, 8, 6. Even numbers denote the right side of the head, and odd number, nombor ganjil, odd number denote the left side of the head. Okay, next. So we use 10/20 EEG placement. It is a very widely used, internationally recognized method. It covers all the brain regions. And then this electrode, we know, is number and letter. So the letter is FTCPO, frontal, temporal, central, parietal, occipital. But C is letter used for identification purpose only. There is no central loop. Next. So uh, 10 to 20 refer to. Actually, 10 to 20 refer to the distance between adjacent electrodes, which is we can put 10% or 20% of the total skull distance from each electrode. So as you can see in the picture, to the left side, there is 10% or 20% distance from the electrode. So as you can see, F is for the frontal, C is for the central, that is the letter that P parietal, O occipital. In it. So basically, electrode have two types. Basically, we can put it separately on the scalp, or it have the special mount, special band we can just put on the patient head. Next. So this is the amplifier. Basically, it's to increase the power of a signal. So it takes an energy from a power supply and controlling the output to match the input signal shape. To match the input signal shape, but with a larger amplitude. So the shape is the same, but we want to amplify the signal. Okay, next. So filter to produce a readable EEG. Readable EEG. So basically, it's to clean up. So if you can see, the original signal is like kind of right. So after filtering, you can get the smooth and readable EEG. So this is writing unit. So this is the writing unit. So basically, it's record the EEG. Okay, next. Okay, so preparation of for EEG, first you must ask consent to do this kind of procedure. So the patient must wash his or his her hair with shampoo to to for the electrical conduction. So the patient also must discontinue medicine that may interfere with the test, such as the anti-epileptic drug, and the patient must avoid any food or drink that contain caffeine. So if the patient having a sleep EEG, so he or she may be asked to stay awake the night before the exam. Okay, next. So for during the EEG, so basically EEG takes about 1 hour. So the technician or the nurse will attach the electrode to the scalp and a gel will be applied to improve the conduction of the impulse to the electrode. So the electrode before the electrode will gather and then produce the result at the last stage. So the technician may tell the patient to breathe slowly and may use visuals such as flashing light to stimulate the brain. This can also induce seizure. So these are the tools that we need to do EEG, measuring tape, wax pencil, measurement cheat sheet. And then the next slide is why we need these tools. So we use alcohol to remove the grease at the hair and the abrasive paste, and cotton tip to reduce the skin impedance. We remove the dead skin cells. So why is because we need to have good electrical contact. So if you do not have good electrical contact or poor placement, so you might get EEG artifact, not ECG, sorry. EEG artifact, movement artifact, high impedance, movement artifact, sweat sway. Okay, next. So after EEG, so the technician will remove the electrode and the patient can resume the medication as usual, such as anti-epileptic, and then they can go home immediately after the test. There is no recovery time is required. Okay. Yeah. Okay, for the result, so the neurologist or technician will interpret the result and told the patient when they have to come to tell the patient about the result. So the neurologist must look at all the recording in the machine, decide what is normal and what is not, and determine what the abnormal tracing represents. Next. Next. Okay, so this is EEG waveform. It's just for the knowledge. Basically, we have classify the EEG waveform according to their frequency, amplitude, and shape. Basically, we can generalize we can have 5 types of EEG waveform, which is delta, theta, alpha, beta, and gamma. So next. Basically, delta is the slowest waveform. Delta is the slowest waveform. It's 1 to 4 cycles a second. It can detect it in a sleep person or the person during anesthesia. So theta is you detect when they're trying to memorize many things, such as many numbers, many words, and the person is in a drowsy state. And the alpha is when you're resting or meditating. Beta in when you do something, when a person is getting ready to move or no longer resting. But gamma is like the delta is the slowest, gamma is the fastest ECG waveform. So this occur when a person is thinking or paying attention. See that? Okay.
So it is, can you hear me?
Yes.
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 Yes, I hope if you have any teaching with me in the future, just we can present one ECG. Okay. Early exposure of you to these things, I think your brain is working good, and if you collect any details now, it will help you in the future. And don't afraid from any practice in medicine. Okay. A good details. I didn't want to overload you by a more knowledge, but remember that your value in medicine is your hand skills and your index of suspicion for medicine. It is very important, okay, to start early exposure for any procedure and try to go deep and get the knowledge for everything. It is very, very important, okay? Okay, we can go for the ATRIUM as the time is running now, okay?
Doctor, could I ask a question?
Okay.
How often will EEG, especially in patient who have diagnosed seizure? But I wanted to know how often it is done in clinical setting.
Really, the voice is not so clear.
How often the EEG is done, especially in patient who has been diagnosed as apa tu?
Yes, as epilepsy.
Epilepsy, yes. I just wanted to know how often that the procedure is done.
Yes. Number one, the diagnosis of epilepsy is a clinical diagnosis. Okay. But in many situations, you need to confirm the type of epilepsy, because epilepsy can be generalized, can be focal, can be. So you need to know, is it generalized or localized or like that? Sometimes EEG will help you for the diagnosis. And the main neurologists prefer, if they are diagnosing the epilepsy, to do the EEG. Okay, in spite of some patient with epilepsy may experience a normal EEG, maybe up to 10%. And the reverse, some normal people has abnormal brain activities, but they don't have convulsion or epilepsy, okay? But usually we did it once for diagnosis and one at the end of the treatment. Usually if it is just straightforward the epilepsy and the responsive, it may be we are going to stop the medication. So before stoppage, many specialists prefer to repeat one to see the change in the brain activity. Sometimes you are doing the EEG for another job, like infection with the herpes simplex. If it is encephalitis, sometimes the EEG, it has its own specific left temporal lobe affection. Also, if you are going to, in a difficult situation, to confirm the death of someone, sometimes you are doing the EEG to see, is it completely flat? Okay. Also, we are doing the EEG for case of neonatal asphyxia. If the baby has perinatal asphyxia, if you are applying EEG, or we have something known as cerebral function monitoring, which is continuous EEG, it can guide us. How severe is it? Mild or moderate or severe, through the electric activities also. Okay. So it looks like you have a weapon in your hand you can use for many things. And with time, there is evolving. Is it okay?
Okay.
Okay.
Thank you, Doctor.
Welcome. Okay, Isa.
All right, so I will be presenting about intubation. So my name is Ali Muhammad Isa. All right, so ET intubation. So first, I'll explain the indication. So for indication, we will use it on patients who have unstable airway, as because we want to protect this and also to maintain the airway. So example of those that can cause unstable airway are like airway infection, like croup, bacterial tracheitis, can be also caused by trauma, any cyst or any mass that can cause a mass effect towards the airway. So we want to protect this airway because we want to prevent the inadequate oxygenation or ventilation. So otherwise it will lead to respiratory failure. So the patient with impaired oxygen will lead to hypoxia and hypocarbia. All right. So, and we also is indicated for patient who has a low GCS. The most common is a GCS of less than or equal to 8, or a very rapid deterioration from 14 to 10. So the reason why it's very important to do on patient with low GCS is because they are very high they have an increased risk of aspiration, and also they are more likely to have that loss of protective airway reflex. So we should determine a patient is able, patient will not be able to have the ability to swallow or handle the secretions. All right, so then and also lower airway obstruction like asthma, bronchiolitis. So but usually intubated in extreme circumstances. So contraindication, next slide. All right. So usually, according to the website up to date, they mention that there's no absolute contraindication, as because it's the first priority to manage the airway, especially in acutely ill or injured children. So so there's relative contraindication. These are actually uncommon, but if they exist, is because of difficult intubation, difficult to ventilate. Then with if there's any suspected laryngeal fracture, and there's a high risk intubation like epiglottitis, because the epiglottitis is the one that covers the airway and it's very inflamed. And then unstable surgical patient, which usually like traumas, because it's very difficult to, it might lead to a lot of complications. So it's usually preferable if doing surgical airway. All right, so the anatomic importance. So the first one is a prominent occiput. Usually, because the prominent occiput will vary the degree of the neck flexion, as the neck flexion usually important to look at the airway. A large tongue compared to large tongue here, it means usually because it occupy that or the airway space compared to the adult, where usually adult the tongue usually doesn't cover that a lot of the airway space. And then large tonsils and adenoids. So usually, as I mentioned, just like the large tongue, it contributes to the airway obstruction. Supralaryngeal position, where it's more chapillate, so therefore it has the more acute angle between the glottic opening and also the base of the tongue. So what happened is that the visualization is very challenging. And next is weaker hypoepiglottic ligament. So if it's weaker, so when we want to use the blade, to lift the epiglottis will not be so effective. And then large floppy epiglottis, which means So when we want to lift, it usually slides down, so it's very hard to lift it. Okay, so shorter trachea. So because when it's shorter, it might very likely to have that bronchus intubation. And then narrow trachea, so it means that there will be increased airway resistance. And then anatomic subglottic narrowing, where the shape is very elliptical compared to adult. So adult is usually a bit more flat. So when it's elliptical, it's very hard to, it more likely there will be a lodge, the foreign body is lodged between the, and then compliant chest wall. So when the chest wall is so compliant, therefore it's likely to experience respiratory muscle fatigue and atelectasis and respiratory failure. Okay, next. So here you can see the summary of difference. So on the right is the pediatric airway, on the left is adult. So you can see the epiglottis is very floppier, usually floppier, large, therefore it's easily to slide and it's very hard, it's harder to lift. The airway is more anterior and higher, and then the narrowest the pediatric, the cricoid ring is very narrow, while the vocal cord in adult is narrow. I think next. So these are the equipment, which I will explain a bit more further later. So these are the list. Okay, next slide. Next. All right, so when doing intubation, ideally we will have 3 practitioners present, which are the laryngoscopic himself. Second is the assistant, usually that will provide the equipment whenever the laryngoscopy is needed. An additional provider, usually the additional provider will be the leader, because it's much more preferable if the laryngoscopic is not the leader who gives the instruction. It's the leader, usually the third person. And also, or we can also have a respiratory specialist who will be assisting with the ventilator management after intubation. So the equipment to monitor the patient, which is to measure the heart rate, respiratory rate, blood pressure, continuous oxygen saturation monitoring, and the capnography. Next. Sorry. All right. So oxygen supply. Usually, the oxygen supply like nasal cannula and also the transparent mask usually should be available. The flow meter should be at least around 10 liters per minute. So, and then we also have the suction. So usually we have these 2 different types of suction. First, let's talk about the pressure. The pressure of the suction should always be around 80 to 120 in pediatric to prevent the trauma to the airway mucosa. All right. So next is it's the 2 types of suction. First is the Yankauer, and second is the flexible one. So Yankauer is more appropriate. It's a straight. It's more rigid. So it's more appropriate for suctioning the particulate matter, while the flexible is used for thin secretion and also for deep suctioning through the endotracheal tube. All right, so the bag and mask, it is it's a mean for oxygenation and ventilation. So basically it's for pre-oxygenation before intubating the patient. especially those who have respiratory failure. And then next is airway, artificial airway, like your oral and nasopharyngeal airway, which to facilitate the back mask ventilation, especially in case the ETT cannot be passed successfully. So these are the equipment that I have mentioned just now. On the left is the proper way to, we have to, when we use the bag and mask, we usually have to select the correct size. So, and also to cover the proper way, which is to cover the mouth, nose, and chin, but not the eyes. Anything that extends over the chin or that covers the eye will be considered incorrect, or that doesn't cover the nose and mouth properly. So this is the bag, which is, we have the different parts, which is the expiratory valve, self-inflating bag. There's an air in, oxygen reservoir socket. All right, so in that reservoir bag. So bottom, we have the two suction. The left is the left is the yang square, and then the right side is the flexible one. Okay, next. All right, so next we have the endotracheal tube itself. So we can, endotracheal tube has the two, which is the cuff and also the uncuff. So the cuff is usually in pediatric patient, usually in infants or young children, usually uncuff is more preferred because we want to prevent that pressure-induced ischemic damage to the tracheal mucosa. So, however, we can also use cuff in younger children when children are at risk for aspiration, those who are burn victims, and also those who have a severe lung disease that require that high ventilator pressure, like chronic lung disease, status asthmaticus. And then next is we have the ETT size for children. Usually is estimated based on age. So let's example, we use uncuff. So we have to do take the patient's age first. Let's say patient is around 4 years old. So it will be 4 age in years divided by 4 will be 1. So 4 plus 1 will be 5. So it will be 5, internal diameter will be 5 mm. And then, however, if this formula will not really be used on very young, like children who are, like, let's say 1 to 2 years old, they use 3.5 millimeter, and those who are less than 1 will be 3 millimeter. All right, next. So this is the ET tube. So we have the inflated cuff, the connector to oxygen source, and then the cuff inflation line. All right, next. So we have the stylet, usually, which it reinforces the ET tube to make it more rigid. So therefore, we can allow the operator to direct the tube into the glottic opening. Then next is the laryngoscope. So this laryngoscope, we have two components, which is the handle and the blade. So the blade, usually we have the pediatric and adult size, but it depends on the clinician, what's his preference. And then for blade, we also have two types of blade, curved blade and straight blade. So the curved blade usually is to allow that easy placement up towards the vallecula. And then the straight blade is to usually use preferred on young children and infant to directly lift the epiglottis, because curved blade is towards the vallicular and then have vallicular, which then you lift, and usually epiglottis will be also be lifted. So straight blade, we want to directly lift it because of the large floppy epiglottis. So all right, so usually before we use, we have to have the appropriate size, usually either one size larger or one size smaller. All right, next. So here's the illustration of how the curved blade and a straight blade. So you can see that the curved blade goes towards the vallicular, which then lift, and also the epiglottis will lift. But since it's floppy, the epiglottis might also flops downward, which makes it harder to intubate. So what's more preferred is a straight one, because straight one is preferable to directly lift together with the epiglottis. Okay, next. So this is the size of the blade. Usually, so around, if young children, they will use 2. However, preterm or very extreme preterm, usually 0, 0 or 0, 1. And those who are already teenagers will be 3. So the curved blade is otherwise called Macintosh, and then straight blade is Miller. And below is the stylet. Okay, next. During emergency, the RSI is preferred. So what is RSI? It's a coordinated sequential process of preparation, sedation, and paralysis to facilitate that safe emergency tracheal intubation. So this RSI really provide optimal condition for emergency intubation, and which independent of the varying level of consciousness or those who have that full stomach, therefore it's able to be used in emergency. So who are the risk factors to have the aspiration are those who have gastric distension from back mass valve ventilation, have an increased intra-abdominal pressure, difficult airway or GI pathology, those who have gastroesophageal reflux, those who have also sepsis, renal failure, or had opioid before operation. So the reason the children have very highly likely to have aspiration because they have a shorter esophagus, obtuse angle of AHIS, and then period of transient LOS relaxation. Next. So for approach to RSI, we can remember the 7P. So preparation, we want to prepare all the correct equipments. Then we want to do pre-oxygenation. Pre-oxygenation to make sure it's oxygen with 100%. And then pre-treatment, usually we give atropine, lidocaine, Robinol, and then we use sedative and also neuromuscular drug like a sedative like intermediate, propofol, paralysis to succinylcholine. And then that's the time we can pass the tube using the direct laryngoscopy and then verify the placement. So that's an overview of the RSI. Next. So the whole procedure itself, we can try to remember, because disintegration is very complex, so we can try to remember the mnemonic: suction, oxygen, airway equipment, pharmacopoeia, positioning, monitoring, and equipment. So okay, next. So monitoring, we want to monitor the cardiorespiratory and also the pulse oximetry before the intubation. And also we want to have the capnography, because once we intubate the patient, we want to confirm the position of the ET tube. And then pre-oxygenation. So we want to administer oxygen before intubation so that we can have that safe apnea time. So this safe apnea time is the duration of time following the cessation of breathing or ventilation until critical arterial desaturation occur, which is 88 to 90% SaO2. So the mechanism is to denitrogenize the lung, denitrogenation, which is to use the oxygen to wash out this nitrogen that in the lung after the breathing room air. Then the purpose is to have that large alveolar oxygen reservoir. Next. So what's the technique? So I will show the picture later. We are on the next slide, which is first to position the patient. And then we do ventilation technique. Either if depending on how many people we have, if it's 1 person or 2 person, I'll explain in detail next slide. And then we ventilate with 100% inspired oxygen, which, as I mentioned just now, to create that oxygen reservoir. So you have to take note, we have to avoid hyperventilation, and a slow ventilation lasting around a second each must be applied, being overall pre-oxygenation phase, duration 3 to 5 minutes. All right, next. So these are the technique. So we learned this during our specialized posting. So one person, we have to use one hand on the mask, where first we have to position the head first, then we use our thumb and the index finger to make the C position, and then our other 3 finger is on to the chin and must be elevated. So the sealing is very important. The 2 person is we use we use the 2 hand. So one person will do the bagging, and then the other person will hold the mask holding the thumb and the index finger in place on the mask, and then the other 3 finger to lift up the chin. Okay, next. All right, so this is how we position the patient. So the 3 points we have to look at is the pharyngeal, tracheal, and oral axis. So we want to, our aim is to align this axis by using the sniffing position. Okay, next. So to do the sniffing position, first we have to align the pharyngeal and the tracheal axis. So first, the chin usually move anteriorly with respect to the shoulder, and then also the external auditory canal will be anterior to the shoulder, and this can be accomplished if it's older children will be placing the towel under the occiput, and then if it's infant, we put the towel under the shoulders. Next, we want to align that oral axis with the pharyngeal and tracheal axis by placing the right hand. So the right hand on the patient, we have the palm of the right hand on the patient's forehead, and then from the palm to the finger will extend all the way to this occiput, and then we gently rotate the head posteriorly.
2 minutes to finish, Ali.
2 minutes. All right.
Yes.
Okay, next. So these are the medication, usually preferably sedative, etomidate, or thiopental. These are very commonly preferred. Next. And then however, there's other complication or any features like any other factors, then we can refer to this table here. Paretic, rocuronium, and succinycolate. Next. So before intubating, we have to look at lemon, mnemonic lemon, which to look for the short neck, large tongue, evaluate the 332, which is 3 finger breadth of the mouth to opening, 3 finger breadth submental to hyoid, or 2 finger breadth higher to the thyroid, which to make sure that it is good to intubate. Others are okay. So next. So the laryngoscopy, so usually when we want to do laryngoscopy, to open the mouth can be done with a scissor technique, where using the thumb towards the lower teeth and then the index finger to the upper teeth, and then we apply, and then as the second picture shown, and then we try to put in the laryngoscopy inside, usually preferably on the right side, and then sweep to the left so that prevent that pharyngeal fold, making it easier to have the view of the glottic opening. Next. So this is the view we can see. Up is the epiglottis, and then we have the glottic opening. Next. So the ET tube, as I mentioned just now, usually we done under direct visualization, and then the depth we want to confirm by first by placing a double line on the uncuffed ETT at the glottis, at the tube, and then usually it's preferably the tip will be at the midpoint between the thoracic inlet and also the carina. And then I insert the tube until centimeter marking on the lip is 3 times the size. Okay, next. So confirm the tube position can be done clinically or using confirmatory device. Clinically, the chest wall will rise, and then next auscultate, and then if any adequate oxygenation by the pulse oximetry, and then mist will be present at ETT. Otherwise, we can confirm with device like the capnography, where there will be end-tidal CO2, or we can use beds ultrasound if very experienced. Next. So securing the tube, usually we can secure the tube using a tape by using the create a white shape, where one of the first creating white shape, and then one of the tape will wrap around the tube, and then another tube will be at the above the upper lip. Next. So post intubation care. So we want to do chest X-ray first because we want to confirm the position of if the tube is really at the trachea, and then we have to do gastric compression, and then and then minimize head movement, and also positive pressure ventilation. Next. So these are the complications before intubate. There might be a gastric distension due to the back mass ventilation. During laryngoscopy, there might be hypoxemia, bradycardia, increased ICP, mechanical trauma, and aspiration. And after intubate, there might be any barotrauma or tube obstruction, any malposition, hypoxemia, and also post-obstructive pulmonary edema. I think that's all.
Okay. 5 minutes for everyone, please. Thank you for this very wide, good presentation. But really, I hope that you try to insist for the practical points. Theoretical parts are very important. At least there is an important advice I used to inform you about that. We are using the laryngoscope. Some are using it as a weapon, sketching it, and they are very roughly. Baby are very fragile. They can even cut the trachea, and the baby will get severe hemorrhage and may die, of course. So we are using the ET tube as a pen, not as a weapon, by 3 fingers. and try to be soft. Don't be very harsh. Of course, you are getting it by our left hand, but don't be very harsh with a small infant. Even you are not allowed to do rub this movement because it will injure also the trachea. You can carry all the tongue and the palate with you, but don't do rubbing. It is very important. Okay, inshallah, during training for NRB, we will discuss that one. Okay, thank you. We need 5 minutes for CBD, please.
Sure.
يعمل ايه؟ ايه يا ابني؟ لخبط نظام نومك ليه؟ Where are you?
Hello.
Yes, you go ahead, please.
Okay, I'll start. Bismillahirrahmanirrahim. Okay, my name is Kizandra Mesara and I'm in charge in presenting this CD. So where I put the picture there is keep, that's all. Okay, so my content is we'll start with anatomy. This is important, we can go through it. Next. So bladder catheter are used for urinary drainage or as a means to collect urine for measurement. So you can see there are two pictures here. Let's go through the anatomy of the bladder catheter so that it is easier for me to explain about the procedure later on. Okay, as you can see, the bladder catheter only involves from the eyelet to the you can see there's two divisions catheter, two ports, which one port is connected to the drainage tube, while the other is for balloon inflation or deflation. The catheter contains the eyelet, which is used, it's a hole to drain the urine. And then below it, there's a soft balloons that can be inflated through a pipe beside the where we connect the drainage tubes. And then the catheter is then connected to the drainage tube and the collection bag. Okay, at the right side, you can see pictures of different types, special catheter, and also it's different, that come with different size. And also the size is represented by a color coded, which is situated at the port where you put a syringe to inflate the balloon. So basically, under the special, you can see there, for example, the caudate. It is a bit curved. It's suitable with patients for obstructive rhopathy secondary to benign pressure. Catheter, it has one extra and at the end, it's much more good compared to normal catheter because it is used in the heart to usually it's an antimicrobial agent to prevent urinary tract infection. That's all. Okay. There are other bladder that we will go through, but before that, let's go indicated conditions of the bladder. So the indications of putting the use of bladder catheter into clinical practice is to, if there is urinary retention, so urinary with or without bladder outlet obstruction. Second, our urine output measurement in critically ill patient. Third, daily urine output measurement for fluid management or diagnostic tests. The fourth one is during surgery to assess fluid status and prevent bladder overdistension. For example, if it's a prolonged bleeder that needs us to monitor the fluid status of a patient, and then if we are required, if the patient are due to the prolonged procedure, the patient require a large volume fluid infusion, so we have to monitor it so that the bladder is not over-distended. And then fifth, during the following specific surgery of the genitourinary tract or adjacent structure, for example, like urologic, gynecologic, colorectal surgery, as this surgery can lead to bladder dysfunction, and they need the bladder catheter to aid them during voiding. It says that from my reading, maybe the patient has to use the bladder catheter for almost 6 months. And then next is management of hematuria associated with clot by using trivial channel catheter type, management of immobilized patient like stroke or pelvic fracture. Okay. And then it is management of patient with neurogenic bladder or spinal cord problem. Next is management of open wound located at the sacral or perineal region in patients who are incontinent. By using catheter, it helps in the healing process of the open wound, especially in patients who are incontinent, by channeling the urine without contacting the place that is exposed to injury. And then intravesical pharmacological therapy, for example, in bladder cancer, where you have to put the drug into the bladder, and then improve patient comfort for end life care. Lastly is management of patient with urinary incontinence following failure of conservative behavior, pharmacological, and surgical therapy. So the contraindication can be further divided into absolute and relative. So the absolute one is if there is a presence of urethral injury, which is typically seen in the pelvic trauma. When there is a presence of blood in the urine tips of the catheter, you have to do the retrograde uretrogram to confirm the trauma site and seek help from the urologic consultation and before putting the bladder catheter, as it is absolute contraindication. Maybe you have to consider other alternatives. Relative, you still are relative. Why it is relative? Because you can put the bladder catheter with a condition. If the benefit outweigh the harm to the patient. Such relative contraindication is urethral stricture, recent urinary tract surgery such as urethral or prostate or bladder, and then presence of an artificial sphincter. We can still use the catheter bladder by deactivate the artificial sphincter during the catheterization, and it is used in the short term. And then we have to consult with urologist first. Okay. The types. Okay, the types. The main types of urinary catheter that can be divided into three: external, external, retral, and suprapubic. Basically, external, it is the least invasive of urine drainage and available in men and women. In men, it available as, for example, in the condom catheter, while in women, they're using pouch catheter. Pouch not used for external. It is only to use for to collect the urine. The aim is to collect the urine, but it is not used in management of urinary obstruction. Not for bladder drainage, only to collect urine. So contraindication is when there is penile ulceration or penile dermatitis, for sure, because for example, you're using the condom catheter, right? You have to put the condom under on top of the skins, and if it is getting too tight or there's a problem there, it can cause an ulceration. But the advantage of using this, it is minimizations of urethral trauma because it is external, it doesn't involve urethra, and it also improves the comfort and mobility of the patient. The disadvantage is irritation. If it is too tight or penile ulceration, scarring or penile tissue loss, others can be dislodgement and spillage of urine. So we go to the urethra. Urethra can be further divided into indwelling and intermittent. Urethral is a catheter that use the transurethral route. So the first one is indwelling. Indwelling in the hospital setting is only used for short-term drainage. It is the most common usage in the clinic yet. I haven't seen others except for this catheter. And then the maximum use is less than 3 weeks. If it is short-term, then it's probably advisable to change. And then it is also suitable to use in management for chronic urinary infection patients who have problems with other intervention. As you know, indwelling catheter, why indwelling catheter is used widely in the hospital, because it can be used in almost all the indications that I list or present before. And then next is intermittent catheter. The difference between indwelling and intermittent catheter is intermittent catheter doesn't have the bulge at the opening at the ends, at the tips, because it doesn't have the balloons. The way in using intermittent, the things to use when we have to use intermittent is because the aim is to immediately remove. The aim is to decompress the urinary bladder within a short time. For example, before a short period of surgery, or it can be used outside of the hospital setting where the patient have urinary incontinence. So they can use these types of catheter, but it need to be recatheterized again, which means you have to put inside. You have to put the catheter inside the bladder again every time you want it to void. The is limited. Not for patients with extreme impairment. It causes discomfort. Not for obesity. Maybe.
تقدر تشربه؟ لا اصل ميرا عملت لي واحد من شويه. طب هات لي نقطه لبن صغيره عليه. شاي لبن جنزبيل ده عزيزيه ده.
Okay, so the suprapubic catheter, it is a most invasive catheter and require a surgical procedure for placement, usually by urologist or urogynecologist. Either intraoperatively in association with another surgical procedure or percutaneously. The advantage of using these types of catheter is it can prevent urethral trauma and stricture formation. It also reduces the incidence of catheter-associated bacteria, at least temporary, but prolonged use can lead to other types of infection, especially at the insertions of the catheter. And then lastly, patient satisfaction is they found that there is no satisfaction using this type of catheter compared to the indwelling urethral catheter in terms of when they will allow the patient to void normally without the need of recatheterization every time they wanted to void, and it also interferes less with the sexual activity. The disadvantage is, of course, it is invasive. Next. This is the summary of the indications and the types of catheter that can be used in certain indication. As you can see that, to highlight, indwelling catheter can be used in almost all the indications. That's why it's widely used in the hospital setting. Next. Preparing and inserting urinary catheter. Next. So there are few steps. First is you have to gather the equipment for the catheterization, such as sterile graph, cotton ball with betadine, lubricant gel, urinary catheter, 10cc syringe, sterile water for balloon inflation, urine drainage system, flashlight or lamp, or a room with adequate lighting, and disposal bag. The second step is you have to explain the procedure to the patient, gain the consent and all. The third is the setting. Make sure when you do this, the privacy is there, and then there is adequate lighting so that you won't misput it, or if there is anything that can block the insertion. The next one is positioning. Urinary catheter incisions in both male and female is almost the same, except that the types of catheter used, I mean by the type is the length of the catheter used, which female tend to be shorter compared to male, and then the patterns of cleaning the natal area, I think that's all the differences. And then the way of putting the collecting urinary bladder back. And then, okay, let's go to the positioning. Men, usually in supine position is enough, and then only exposed area around the penis. Catheter is set in place next to the leg of the patient, while women is positions in the front leg. Later you will see the picture. And then you have to cover the upper body and the leg together, and the catheter is set in place between the female patient legs. Number 5, pre-catheter insertion. Before inserting the catheter, ask the patient, if you can, ask the patient to cleanse the genital and perineal area with warm soap and water, rinse and dry. And then what you must do is you have to wash your hand. Wash your hand thoroughly using the what Azlan has shared, the technique, first-step technique. Open the catheterization kit using a sterile technique. Sterile gloves are donned, and the catheterization kit is inspected to ensure its contents are complete and free of defect. Apply sterile lubricant lid catheter kit. Lubricate at least 6 inches of the catheter. Leave the lubricated catheter on the sterile film. Make sure you leave the lubricated catheter on the sterile film, as the tips of the catheter is used to insert into the urethra. So you need to be as sterile as and antiseptic over the cotton ball. Place during you be overwhelmed or anxious or lose yourself in the and the patients are clean. How do we next? Next slide. Next slide. Okay.
Is it the last slide, Maisara?
So, sorry, doctor, my line is not that clear tonight.
Okay. Okay, the next slide, please. The next slide. Is it the last one?
No. But in if this course, it is the last one.
Okay.
Men and women.
Yeah, no need for percutaneous suprapubic catheter. It is something advanced. What is the next one? Okay.
Men and women, how to sterilize, how to clean it, and then how both inflate the balloons and all that.
Yeah. Okay. Next one. Catheter care. Okay. The next one. Yeah. Just tell us the complication.
Complication. All right. Hold on. Okay. So complications. Generally, the complications of erythrobladder is bacteria and urinary tract infection. Recurrent urinary tract infection as a result of chronic catheter use. So only use the catheter until there is no indication to use it, which means you have to stop using the catheter as soon as you found there is no indication to use it, because chronic use of catheter can lead to a chronic failure, and it also can cause epididymitis that can lead to orchitis. And then next complication is return balloon fragment. If you over distended it, it can it can rupture, or it can spontaneously rupture due to maybe the material or that is encountered before the infection. That is why you have to check for the balloon infection, but in our setting we don't necessarily do that. And then the bladder fistula, the presence of air or feces in the urine of a patient with an indwelling catheter may indicate the formations of a fistula. It more likely to occur in the setting of prolonged catheterization with risk factors such as malignancy, inflammation, and radiotherapy or trauma. Bladder perforation, it can occur either intraperitoneal or extraperitoneal. It is due to long-term indwelling catheters. Usually, hematuria and the nepin may indicate there is an acute perforation. You can free only in the intraperitoneal perforation type of injury. Then bladder stone formation. Whenever there is a presence of foreign body in the body, the percentage to form stone is higher. And then when using catheter, it will attract all these bacteria, will colonize and all. Bacteria such as Proteus mirabilis can help in bladder stone formation. So specific complication based on the types of catheter.
This one, Maisara, is it applicable for pediatric population? Because usually we are not using it for a long period, like internal medicine. There is a handicapped patient who need. So theoretically can occur, but we didn't saw it a lot in pediatrics. Even for our cerebral palsy patient, we have something known as intermittent catheterization. We are teaching
intermittent.
If he has atonic bladder, we are teaching the adolescent male or female how to do intermittent catheterization. It will prevent the kidney failure and the kidney injury. Okay, it's very important.
Okay.
So usually we are using it intermittent. So yes, I agree for some of this complication, but some is not available. Okay, thank you, Maisara.
All right.
Now I need you to send me the important point is all your name and the presentation which you did. So I can give you marking. For the last one, which is the central line, I think your colleague you will collect all your presentation in one file, as that file I sent you before, and make its name is procedure for year 5, batch year 2021. Okay. And you send me all the name, everyone who is presenting, so I can give you marking, inshallah. At the end, I hope you can understand now your responsibility. It is unlimited procedures. You must know details about that, and soon. Days are running very soon. It may be within 1 year. You need to work as a house officer and to start your practice for all of that. Okay. Thank you for your nice presentation, and sorry for some of your colleagues did a long presentation, hoping it give you some benefits. Okay, and see you inshallah again. Thank you very much.
Thank you, Doctor.
Thank you,
You are
Doctor.
welcome. You
Thank
are
you, Doctor.
welcome.
Thank you, Doctor.
Waiting to send me the names of presentation, and everyone revise his presentation and complete it, and in one file, please. Okay.
Okay, sorry, Doctor, for the internet problems and all.
For what?
For the internet problems and all.
I cannot understand.
Internet. My internet connection.
What to do? We must accept something, hoping most of the presentation are clear. If there is some interruption, okay, it's accepted for me. Okay. Thank you.
Thank you, Doctor.
Assalamu
Thank you,
alaikum.
Doctor. Waalaikumsalam.
Thank you, Doctor.
Welcome.
Thank you, Doctor.
Barakallahu fikum. See you inshallah soon.